we ranked 14th. So we're spending a lot, but we're not necessarily producing the best outcomes. Actually, another group, the Commonwealth Fund, looked at 7 major economies, the Australia, Canada, Germany, Netherlands, New Zealand, the United Kingdom, and the United States, 7. And they ranked us 7th in terms of healthcare system performance. So those are some of the big factors that are driving why we have health reform. Where are we now? What's been implemented? A lot of things have already come out. I guess the thing I want to say before I get started on this is a personal opinion of this person standing here that, and I don't know if anybody in the audience is from the media, but at least at the national level, I don't think the media has covered this particularly well. I think a lot of Americans think that healthcare reform started October 1st, 2013 with the opening of the health marketplace. And that's not true. Healthcare reform started in 2010. It's just it hasn't gotten visibility. So the things I want to talk about here are things that have already been implemented and are being implemented. Affordability of prescription drugs for seniors. There's over 9,000 North Dakota Medicare recipients who have saved $6 million in prescription drugs because of some of the changes associated with the Affordable Care Act. The donut hole, you might be familiar with that, but in case you're not, when prescription drug benefits started in 2002, 2003, there was what's called the donut hole. In other words, prescription drugs are covered up to a certain amount. I think it's roughly around $4,000. And then there's a gap where the Medicare beneficiary is responsible for the entire cost of the prescriptions. And then at around $7,000 or $8,000, the benefit kicks in again. So that gap in the middle that Medicare beneficiaries were entirely responsible for was called the donut hole. So what the Affordable Care Act is, it starts backfilling that donut hole. So that element has been cut by about 50%. It's going to cost a fair amount of money to fill this in. So basically over about an 8 or 9 year period, the rest of that donut hole will get filled in. So there's been about 4,000 North Dakotans who are seniors who are in Medicare who have benefits from that. Preventive services without co-pays and deductibles first got started for Medicare recipients. About 71,000 North Dakotans are benefiting from that. Preventive services in private plans with no co-pay and deductibles are out as well. Young adults, for those of you who have children or grandchildren who are 18 to 26, they can be covered now under their parents' health insurance plan. That's impacting roughly 5,000 young North Dakotans. As I mentioned, the ending of pre-existing conditions. This started in September 2013, just a month or so ago, for children. So there's roughly 34,000 North Dakota children who, because they have a pre-existing condition that cannot be held against them or their family, and they'll have coverage. And then for adults, it'll start in January of next year, and it'll impact over 200,000 North Dakotans. Removing of the lifetime limits on health benefits. A lot of plans were maybe $1 million or so over a lifetime. That's been lifted. Medicaid expansion, you've heard about that. I say 133%, and it's actually really works out to be 137%, but regardless, 137% of federal poverty level. So that'll impact about 20 to 30,000 North Dakotans. This is probably the best deal the states are ever going to get from the federal government. Medicaid typically works now where, and I know we have people here who are more expert than I am, where a lot of times it's about 50-50 in North Dakota. I think maybe we pay, what, about 48%? 50, we are 50%. So the Medicaid dollar in North Dakota, roughly 50% of it is federal, 50% of it is state. But for the Medicaid expansion, this switches to, for the first 3 years, it's 100% by the federal government, and then it gradually goes down to 90%, and it won't go below 90%. So in those situations, with that expansion, 90% of that cost is a federal responsibility, and only 10% of it is a state responsibility. As you know, North Dakota was one of the states that approved Medicaid expansion. So that'll impact somewhere between 20 and 30,000 North Dakotans. There's small business tax credits that are out there. That's going to impact roughly 18,000 North Dakota small businesses. Accountable care organizations, something that probably most of you, maybe all of you have not heard about, for basically a bit of a policy wonk at the University of North Dakota. This is one of the areas that I'm really, really intrigued about. Accountable care organizations basically are kind of new ways of creating networks of providers. Typically, it would be providers, different types of providers, but they would probably be associated with a condition. So maybe providers who are working with diabetic patients or people with heart disease or people with cancer. The Accountable Care Organization will set in place different things to have a higher level of care coordination for that patient, where that patient is monitored and that they're basically ferreted through the system. So there's always somebody who's basically responsible for them, making sure that the type of care that they need is being applied, that they're not being lost in the system, that they're getting reminder calls, a whole series of things, basically to emphasize more of the prevention. There's probably about 400 or 450 accountable care organizations in the United States today. Maybe a couple hundred of them are Medicare. Medicare was the first one. We have 4 Blue Cross Blue Shield accountable care organizations that are called total cost of care contracts, and those are operating with the larger systems in the state. And then Essentia has the one Medicare ACO. The first type of Medicare ACOs were called the Pioneer ACOs because they were the first ones. In looking at the first 32 around the country, the first 32 Medicare ACOs, when they were examined and analyzed for quality indicators, there were 15 quality indicators that were looked at for quality of care. And for all 15 quality indicators, those ACOs saw improvement in the overall quality of care to their patients relative or in comparison to private plans. In addition, those accountable care organizations saved Medicare about $88 million. The Congressional Budget Office basically is estimating that over roughly a 5-year period, accountable care organizations will maybe save the Medicare system about $5 billion. So it's something that I'm very much interested in. My final slide, what are some of the overarching themes in health reform? There's a number of them. Things such as basically a greater emphasis on prevention, a greater emphasis on individual responsibility, hence the individual mandate that we carry insurance. And I know that's an issue for some people. I think the logic and the rationale behind that is that we have a healthcare system now where we have a number of people who, and I don't mean this to be as a pejorative, but they're kind of called free riders, where they don't have health insurance, but we know that when people really, really get sick, they're going to go, such as into an ER, and that is a tremendous cost that's borne particularly by the providers. So people will go in when they're really, really sick, putting an emphasis on prevention, making sure that people have health insurance coverage. The theory behind this is that the emphasis on prevention, having more people insured, will actually, over a period of time, lower our costs in the country. So we'll see if this works out. I think the other thing that's important to understand is, right now, if you're a doctor or you're a hospital, and you treat me, and I've had a number of health illnesses over the years, basically, whether I get well or not, that provider gets paid. If I'm cured, they're paid X amount. If I'm not cured, they're paid basically the same amount. I might be coming in more. What the Affordable Care Act is really trying to do too is change the payment system. So providers will be paid more and more based on the outcomes. In other words, if providers show over a period of time that their diabetic patients are staying where they should with their A1C or their glucose, those providers will get a boost in their payment. They'll be rewarded for having good outcomes. At the same time, if over a period of time they see that the outcomes aren't positive, then there'll be basically a cutback. So I had a conversation with Congressman Kramer once where I basically tried to explain this as, in a way, it's a little bit like merit pay for providers. If the outcomes are good, you're going to get more. If the outcomes aren't good, you're not going to get as much. So, and again, before, you're basically paid the same amount. So it's putting more of an onus on being able to do the absolute best you can and keep the quality high. So I think I'll leave it at that. I think I've covered it. Probably went a little longer than I didn't grab work. Sharon was giving me kudos for actually keeping it controlled. I think I went over. I think the order that we're looking at now, just so I can tell you, the next speaker will be Pat Belmore from Blue Cross Blue Shield, and then we'll